Dr. Alicia Allen began working in clinical research in substance use disorders in 2001. This experience prompted her to obtain her master's in community health education, graduate certification in addiction studies, and doctorate in social and behavioral epidemiology, all from the University of Minnesota. Since arriving at the University of Arizona in 2016, Dr. Allen's research is focused on the intersection between substance misuse, nicotine, tobacco, cannabis, and opioids, and women's health. In 2020, Dr. Allen received the prestigious National Institute of Health New Innovator Award to explore how postpartum hormones influence relapse to opioids. Her talk today will be titled Hormonal Response to Infant Caregiving, a Novel Strategy to Prevent Postpartum Relapse and Opioid Misuse.
Thanks again for having me, and I am going to just basically talk about this new innovator award I got and kind of how I got to the point of applying it and what we're hoping to do. So with that said, there's three objectives today. So first of all, kind of just briefly become familiar with what is known about hormones in substance use disorder, and then what the limitations of that knowledge are. And then thirdly, learn about the potential role of hormones as well as infant caregiving on the risk for relapse to postpartum opioid misuse. So to start off, we'll focus then on hormones and substance use disorder. And to get us all on the same page, I just wanted to talk a little bit about what I mean when I say hormones. So for the first part of this talk, when I say hormones, I'm exclusively focused on ovarian hormones and specifically progesterone and estradiol. So those are two hormones that actually both men and women have, but they're more thought of as female hormones because they have play a major role in fertility and reproduction, and the menstrual cycle and lactation. So they play a huge role in female biology, but they also play a role in like estradiol and bone health, and both of them in mood and brain function. So as you can see from this figure here, the hormonal patterns change quite a bit over the course of a woman's life. So in childhood, they're stable and flat, and that's actually how they are typically in males as well. And then once a teen goes through puberty and into her reproductive years, there's a cyclical pattern to these hormones up until perimenopause, where that's kind of characterized by a time of hormones are sort of just all over the board. They may be going up or down, or that sort of thing. And then into menopause, they start to go back to flat again. So my work has focused mostly on this period of the reproductive age. So if we zoom into that space a little bit, here's the patterns we'll see. So this is a kind of a very simplistic figure showing what the hormones estradiol and progesterone do over the course of the menstrual cycle. So if we think about day 0 or day 1, which is when the menses starts, both hormones are fairly flat, and then estradiol peaks just right before ovulation, then it goes back down a little bit, then both of the hormones get higher in the luteal phase, or right before ovulation. Right before menses. Another thing that can happen in a woman of reproductive age is this B figure, which you can see is just very flat, and that tends to be what happens with females who are on hormonal contraceptives. So typically speaking, the way hormonal contraceptives work is it blocks ovulation from occurring, and because of that, the hormones tend to be more flat across the menstrual cycle. The other big event, as I'm sure you all know, and that's probably part of the reason why you're here, is during the perinatal period. So during pregnancy, both progesterone and estradiol go up a lot over the course of the pregnancy, and then after delivery, they both drop pretty dramatically. So, those are sort of the patterns that I want you to be thinking about as we move forward here. So how does that relate then to substance use disorder? I think it's primarily through these two functions that estradiol and progesterone have, both on mood and brain function. So I'll say a little bit more about that next. So if we're thinking about estradiol, you can kind of think about that as a facilitator for substance use disorders. And I'm putting a couple examples up here. So in the preclinical literature, in rats who are overactimized, so they take out their ovaries, which means their estradiol level goes very, very low, if any at all. And in those rats, nicotine reward is completely eliminated. And then when they give them exogenous estrogen, their nicotine intake increases in a dose-dependent manner. So the more estrogen they're getting, the more nicotine they want to take in. And it also enhances, estrogen also enhances dopamine release in response to nicotine. So the preclinical literature is very clear that, like it just says here, when estrogen's on board, nicotine and many other substances is more rewarding. It gets a little messier when we look at clinical research, but here's a couple examples. So during the follicular phase, which again, this is when the estrogen is low in women, first, we've seen reduced absorption of nicotine. So this is a figure from one of our studies where we had women come in, women who smoked cigarettes, and they came in during the follicular, low estrogen, and luteal, higher estrogen phase. And they used nicotine nasal spray. And we did a kind of pharmacokinetic study and measured their nicotine level in their blood for actually up to 2 hours after. And you can see this dashed line here, which is the follicular phase. There's much more nicotine intake absorbed into their body compared to the luteal phase. And this is a within-person comparison. So, you know, arguably pretty strong data. So there's more nicotine being absorbed in the follicular phase. We also know from some work from Neil Benowitz's group and others that nicotine metabolism can be altered by them by hormonal contraceptive pills that contain estrogen. So that is some additional evidence that estrogen alters the metabolism of nicotine. And then another piece that I thought was really interesting is some cue-induced craving evidence. So this was from Terry Franklin's group at UPenn. So she started out by comparing males versus females in a cue-induced paradigm. So she showed them, these are males and females who've been abstaining from cigarette smoking, and she showed them images to try to elicit some craving response. So for both males and females, they increased their craving, maybe by 1 point to 1.5 points after seeing those images. But this is what's really striking, right? Is if you split up the females by follicular versus luteal, then you see there's a difference in their craving. So, I tend to think of estradiol as a facilitator, but there are definitely some caveats to that, which I'm not going to get into, but just know that there are some caveats. And I'll kind of come back to that a little bit in a moment. So progesterone, on the other hand, is thought of as a hormone that protects against substance use behavior. So there's similar preclinical literature as estradiol, kind of showing the opposite direction. But what I'm going to show you here is what we've seen in human research with delivery of exogenous progesterone. So first, in men and women, there have been studies that have looked at, if you give them progesterone versus placebo in a lab-based setting, it will reduce their craving, urges to smoke, and a variety of different adverse moods. And it also increases their cognitive performance. If we look at women of reproductive age specifically, we have the same effect in terms of reduction in craving, urges, and adverse mood when progesterone is given. But we've also done some studies to see what happens with women who want to quit smoking when they're given progesterone. And that's what this figure is here. And hopefully you can see it okay. But this is a survival curve where the blue line are those who are on placebo and the red line are those who are on progesterone. So as you can see, the blue line with the 52 women on placebo was consistently lower than those on progesterone. So the exogenous delivery of progesterone helped women avoid relapse. Interestingly, we did this study with men as well, and it basically had no effect in men. So it seems to be that it works better, or at least works more in women. So that was kind of interesting. Then the next one I'll share is that during postpartum specifically. So both our group and Dr. Forey group, who's at Yale, did a study, small pilot studies. We both did two with one. Ours had 46 women and hers had 41 women. And both of them, we gave progesterone versus placebo starting at the 4th day postpartum and followed them for relapse. And we both saw the same thing, which was really encouraging, that those who received progesterone were less likely to relapse, but also less likely to lapse. So what this one shows is the blue line are those who are on placebo, red line is those who are on progesterone. So what we see here is that so these are all people who had at least one cigarette, and that's what day 0 is. And you see the pattern with those who have a cigarette is their craving continues to increase if they're on placebo. Whereas those in progesterone, their craving decreases after they have that one cigarette. And so basically what this suggests is that if they have progesterone, exogenous progesterone on board, that maybe that initial slip is not as satiating as they expected it. It doesn't feel as good. And so that may protect them against a full relapse if they have that one single slip. So again, you can kind of think of progesterone as being protective. So that's my very brief and crude summary of what we know about hormones and substance use disorder. I'll also add that much of the work has been focused on nicotine, but there's been a lot on cocaine as well. And they tend to show the same patterns. So with that, I'm going to move along to these 4 things that were floating around in my brain about hormones and how that kind of led to this grant. So like I just shared, we know that hormones change dramatically during the perinatal period, right? I already talked about how they go up and drop down, but then they also vary a lot in the postpartum period. So this is an example of what the hormones may look like in a woman who's not breastfeeding. If a woman was breastfeeding and not getting her menstrual cycle, they'd be pretty low and flat. The second thing we know, which I also just shared, is that we know they alter the drug metabolism, like I showed in this figure, and also the neurobiological drug reward response, right? The third thing, which I sort of alluded to but didn't talk about in great detail, is that we can give exogenous hormones to alter what the hormone levels are, right? So the progesterone that I mentioned is what we used in our smoking cessation study as well as our postpartum relapse study. And what that does, as you could probably guess, is it increases progesterone levels in the body. Another approach that we're using in another study right now is Depo-Provera, which is the birth control shot. And what that does is it prevents ovulation for 3 months, which basically means the estradiol is low. So if you put these 2 together, this is the kind of the pattern you'd see in the postpartum period. Progesterone would be high, and estradiol would be low. So based on what we know about the hormones, that should be advantageous for quitting smoking or potentially opioid misuse as well, right? Now the 4th thing, which I haven't, or actually before I get to that, there's all of that together suggests that there is a way potentially to utilize hormones to prevent and treat substance use disorders. But of course, there are some limitations. So the limitations to date is most of the research has focused on 1 or 2 substances, primarily nicotine and cocaine, and oftentimes it would be nicotine by itself or cocaine by itself, so not really looking at polysubstance use. Oftentimes it's focused on 1 or 2 hormones like the progesterone or estradiol, and that's often done either, progesterone by itself or estradiol by itself, or sometimes it'll be what's called the progesterone to estradiol ratio, but usually that's about it. And then it's also usually focused on 1 or 2 time points. So it might be the hormones on quit day, or the hormones at like week 1 postpartum, and how that relates to what happened when we connected with them at follow-up and if they relapsed or not. A lot of it is done within tightly controlled lab settings. So, there's questions about how that relates to life in kind of the real world. And then lastly, it is always within an individual biology. So we, look at kind of effects of hormones during pregnancy in the perinatal period, the effect of the menstrual cycle, or what happens when exogenous hormones are administered. So the interesting thing that I was learning before applying this grant is, but hormonal biology is not in a kind of individual bubble. So the 4th thing I was floating around in my head is that hormones can change in response to specific caregiving activities. So I was connected with a colleague who, her name is Dr. Stacy Teacott at the University of Arizona, and she studies hormonal responses to infant caregiving and family caregiving in lemurs. And she was describing how, apparently in lemurs, their family structure is pretty intact. And so if, dad lemur is playing with baby lemur, mom's hormones will change in response to that. So it was like really fascinating to think about, how specific infant caregiving activities might play a role in what happens in terms of mom's substance use in the postpartum. So these are just a couple examples. So this is looking at oxytocin, which I haven't spoke much about yet, but is another hormone kind of commonly known as the love or bonding hormone. So this is looking at mom's hormones at baseline. So mom and baby come in, then they play in the lab for a while, and you can see if they have a secure attachment, oxytocin levels go up. Then they do a mirror interaction, which is a more structured type of interaction. And you can see that, they start kind of the hormone or oxytocin starts to decline a little bit until baseline. And the exact opposite pattern happens in those who have an insecure attachment. And here's another example. So this is skin to skin contact. So you can see in moms who are doing skin to skin with their baby, their hormones go up while they're doing skin to skin, and then it declines. And a similar pattern also happens in fathers. So, that kind of got me thinking is, we know some things about infant caregiving, like, for example, breastfeeding is known to be protective against smoking relapse and other substance use. And I think it's often thought of as that's true because, mom may be more health conscious or maybe more susceptible to making, maybe I shouldn't say susceptible, more likely to make healthy behavior changes. And that's what's keeping her from, going back to smoking, for example. But I was starting to wonder, like, what if it is really the hormones that are at play? So, so those were all sort of those four things about hormones were floating around in my brain. When I came across this, so this was that new investigator award. So it's part of the high risk, high reward research program, and it's for early career investigators. And basically what you need to do, it's written up in a really strange way, but what you need to do is sort of propose a kind of a seemingly strange intervention for a public health problem that has yet to be addressed. And so, we know that opioid use disorder is increasing in pregnancy, and infants with neonatal abstinence syndrome are becoming more common. And we also knew all these things about hormones. So maybe there's a way to put those two together. So that's exactly what I proposed and tried to do. So we're, with this work, trying to figure out how we can utilize the power of hormones to protect women and their families against postpartum relapse. So before I get into that, just a tiny little bit of background about opioid relapse and overdose risk. So this quote here is just something that really inspires me with a lot of the work I do. It's from Dr. David Olds, who's, I believe, the creator of the Nurse Family Partnership. And he says, there's a magic window during pregnancy. It's a time when the desire to be a good mother and raise a healthy, happy child creates motivation to overcome incredible obstacles. So, and I think we can see that here, right? So, these are overdose events by postpartum period. So there's more risk for overdose prior to pregnancy and in the first trimester. And then, when mom becomes, aware of pregnancy and, potentially connecting and bonding with baby, and probably also having increased, support from those around her, more access to healthcare, probably many other things, but this overdose risk goes down quite a bit. Then you can see, unfortunately, after baby, the overdose risk continues to increase. And so it just feels like, such a missed opportunity. They did so much great work here. Let's figure out a way to extend that into the postpartum. So currently, the American College of Obstetrics and Gynecology and American Society of Addiction Medicine, they have a statement out on how to care for opioid use disorder during the perinatal period. And one of the bullets says there should be access to adequate and presumably effective postpartum relapse prevention programs and they should be made available. But there actually are none. So there literally are no evidence-based prevention programs for opioid use disorder for the postpartum period. And that's not to say, women and families potentially should not continue with their medication-assisted therapy and behavioral counseling. Those definitely should happen, and they definitely are recommended, but there are no specific approaches to preventing relapse specifically. So what we want to do is try to figure out a way to add kind of another layer of protection onto the MAT and behavioral counseling and peer support and so on that they're already getting. So, yay, we got this grant. So that's kind of, that's what happened, and that's the title of the grant. And I'm gonna just go through them. We are proposing like 4 big picture steps. So I'm gonna walk through those steps and share kind of what we're doing. So the first step is we're collecting a bunch of data, which is what I will talk about next. So this was the figure that we proposed in the grant. And you can see it's a lot, but basically we know there's lots and lots of background variables, right? So demographics, history of their OUD when they started, if they're in treatment, their relapse history, are they using other substances, what's going on with their physical and mental health, their emotional health, and what kind of social network do they have. Those are all like known to influence both retention and kind of compliance with MAT treatment and also relapse risk. So we're collecting all of those things as background variables. But in this box here is kind of our primary conceptual model. So we have a bunch of hormones that we think may directly influence OUD-related outcomes, which for this study we've defined as craving, compliance with their MAT, a lapse or a single instance of use, and then full relapse. But we also recognize that it's very likely that they're going through these other paths. So maybe the hormones are either altering or being altered by infant caregiving activities, and that could be related to our outcomes. But same goes for a variety of different kind of mood-related type relapse risks. So, postpartum depression is extremely common in the postpartum period, as is anxiety, stress, isolation, and loneliness, how they're doing in terms of bonding and attachment with baby. So that's the other piece that could be at play. So basically, we took all of that and designed a study that is our first step in this grant. We're lovingly calling it the ORCID study, which stands for observing relationships between caregiving and hormones after infant delivery. And what we're doing is, so we're enrolling 2 groups of women. And I should point out that when I say women, I don't mean to imply that we're only enrolling cisgendered people. So as long as they're pregnant, they have the female reproductive parts to support pregnancy, and are not taking any exogenous hormones, we're happy to enroll them. And so we're looking for 50 with opioid use disorder, and then 25 control participants without opioid use disorder. And what we do then, in kind of a very brief nutshell, is we enroll them at anywhere from 30 to 40 weeks gestation. They come in for a baseline visit at about 36 to 40 weeks gestation, where we do collect a bunch of baseline measures, like I mentioned, and we train them on the approaches for the data collection for the upcoming time points. And then we follow them with weekly visits and some additional things through the 4th trimester, which is postpartum week 12. Then we do checkups and follow-ups with them at postpartum month 4 and 5. And we do relapse monitoring through month 12 postpartum. And the way we do those things are listed here. So they do daily ecological momentary assessments. And then on a weekly basis, we do some other interviews and surveys with them. And we also collect their hormones on a weekly basis. And we're monitoring relapse both by self-report, but as well as through their electronic medical record at their MAT clinics. So we'll be able to assess it through postpartum month 12. And I'll go through these measures in a little bit more detail here. So first of all, in terms of the hormones, we're collecting 21 different hormones, which sounds like a lot, and admittedly it is a lot. We focused on collecting hormones that play a role in kind of reproductive, mood type hormones, as well as bonding and I think that about covers it. So the first one we do is cortisol, which is, a stress-related biomarker. So we do an 8 p.m. saliva cortisol sample and another one at waking, and that difference between those two is a indicator of kind of their overall stress, you can say, in a nutshell. Then they come in for a clinic visit and we collect their plasma and we measure that in oxytocin and vasopressin. And we also collect through the blood that we collect, we do dried blood spots. So that gives us a lot of different hormones. So we get 4 different types of estrogens, 3 different types of progesterone, 6 different types of androgens, which includes testosterone, and then 5 other ones. So there's a lot of different hormones we're collecting, many of which have not been studied in relationship to substance use disorders. So we're doing that. Then we're also measuring a bunch of stuff about caregiving. So on a daily basis, we ask mom to assess how much time she's doing these different types of caregiving. And this again goes back to the work based on lemurs and some other animal models. So we kind of assess on a daily basis, how much time are you spending in skin-to-skin contact with baby? And then how much time are you spending in other contact or like closed contact, just holding baby or rocking baby? How much time are you spending with baby like in the same room, but not necessarily in contact, like baby's in the crib or, sitting in a seat playing? How much time is someone else caring for baby when you're around? And then how much time are you away from baby? So that's done on like a slider scale where they say, much more than normal versus much less than normal. So they don't have to actually quantify everything. And then we do a couple weekly validated measures about infant behavior questions and then father and other involvement. The next 2 categories is substance use. So in addition to looking at opioid use, we're assessing 17 different kinds of substances. So that ranges from everything to caffeine and alcohol to cigarettes and methamphetamine and kind of over-the-counter pain medications. So a lot of different types of substances we're collecting. So we do a pretty thorough assessment at baseline. And then once they're enrolled in the study, we do a self-report on a daily basis of craving and use for anything that they endorsed using, I think within the last 3 months within the 3 months prior to pregnancy. Then on a weekly basis, we do the timeline follow back to get more details about how much, or if there was any use and how much was used. And then, like I mentioned, we use the electronic medical records to look at their compliance to treatment and then also their toxicology screen results. So the last thing I'll mention is that we do a lot of those other items. So that kind of far box on our figure. So in addition to, typical things like demographics and mood and that sort of thing, we've also included several measures to look at trauma and resiliency. So at baseline, we do a lifetime history trauma interview, and we follow that up later in the study. And then we're also including some, what I think are kind of novel items in terms of sleep and postpartum pain, as well as how mom's doing with bonding and getting support from her support system and how she's functioning overall. So I know that sounds like a lot, and we're probably thinking, boy, we're going to be asking a lot of our participants. So I kind of broke it down like this to give you a little bit of a feel of what the participants are actually doing. So this is an example week, and don't worry about knowing these acronyms. All these acronyms stand for specific surveys. So you can imagine roughly about 10 to 15 minutes on 6 out of 7 days a week, participants do surveys in the evening time. So I think it's at 8 o'clock is when they get their first prompt to do a survey, and ranges from 9 minutes one day to up to 16 minutes on another day. So that's pretty doable. And then once a week, it might be about an hour and a half of their time total, where they're doing another 10 minutes of survey at home. They collect those 2 saliva samples from home, and then they come in to meet with our study staff. I said for about an hour, but we're actually finding it's probably closer to a half hour. So basically all we do is do a blood draw. They fill out a couple other forms. We make sure the at-home data collection is going okay, and then we pay them and we send them on their way. So the participant we have furthest along right now is at week 5 in this, and she's given us lots of good feedback that this is very manageable, and she's doing great. So we hope that continues. So then in theory, we move on to step 2. So what are we going to do with all this data? So this is another part that's kind of novel about this, is we're partnering with our engineering colleagues to do these analyses. So, so like I mentioned, part of the problem with the state of the science right now is much of the analyses to date has been done with 1 or 2 hormones at 1 or 2 time points. And we know it's much more complicated than that, right? So I think my animation might be a little goofy here. So ignore that for a second and look at the text. We're going to do data-driven predictive analytics. And basically what that's going to do is, number 1, we'll be able to look or identify absolute levels and pattern differences by group. So the OUD group versus the control group. And that's in all of those data. So it could be the hormones, it could be the infant caregiving, it could be probably will be the trauma history. So all of that is we're going to figure out how the data differ between the 2 groups. Then the second step is, once we know that, we're going to look within the OUD group and do the same thing to compare those who relapsed versus those who did not. So ultimately, then we'll put those 2 pieces of information together and be able to look at what were the specific levels or patterns that we saw in the OUD group that did not relapse. So now I can direct your attention to this figure. So if you're like me, this is admittedly quite over my head, but I trust my engineering partners, and this is what you can kind of think of what would happen. So this is another project we have with our engineering partners that's about postpartum relapse. So basically what they do is, so this A panel is craving data over time, with the red dots are those who relapsed and the blue dots are those who stayed abstinent. So they plotted the data for craving and withdrawal with these dots over time. And then they do their math magic and they come up with these lines. So this red line is the expected pattern of craving for those who relapsed, and the blue line is those for who did not. They do the same thing with withdrawal. And then the overall pattern here is they combine craving and withdrawal. And so what these lines here represent is, this black line is when relapse occurred, and this pink line is when the data started to separate. So we would expect something like this, where we could say, you know, well, based on their craving and withdrawal, you know, 20 days before they relapsed or whatever it may be, we're going to start seeing those items peak. And so that might be like, oh, maybe the progesterone starts to go low, or maybe they stop doing skin to skin with baby, or that sort of thing. So we'll have some clues on what's happening before relapse that seems to be related to relapse. So that's how that piece will work. So in theory, that'll all work, and we'll walk away with some great information. And then that moves on to step 3. So what are we going to do with that information? So we're going to go, then we have an expert panel established that has 5 people on it. So we have an expert in skin to skin care, an expert in kind of familial hormonal, you know, changes, somebody who is an expert in how the hormones interact with the neurobiology, especially the drug reward response system, somebody from pharmacy, somebody from stress response, and I think I'm forgetting one person, but, you know, a variety of perspectives on this expert panel. And we're going to bring these data in. We're going to talk with them about what do we think could actually be, you know, a feasible target. And I think, broadly speaking, what our 3 options are is, first of all, and honestly, in my fantasy, it would be specific caregiving activities. Like, I would love to be able to, you know, see that, you know, if mom does 10 to 10 minutes of skin to skin care, you know, for the first 8 weeks or something, then she's protected well into the postpartum. Like, that seems like an amazing option. So hopefully we see something like that. And the second option is maybe we use some form of exogenous hormones to manipulate the hormones into, you know, a level or a pattern that we think is going to be effective. The third option, which I think would not be as ideal because it probably would be a little trickier and harder to implement. But I have a colleague in my department who does a lot of work with diabetes and continuous glucose monitoring. So maybe there'd be something like that where we design a, continuous progesterone monitor, and we can see like, oh, when it starts to dip, go ahead and make sure you take one of your progesterone pills, or make sure you cuddle with baby for a little while. And so it's kind of a more kind of in real time type monitoring, so we can make choices and decisions based on that. So in theory, then all that would happen. And if time allows, then we'll do the step 4, which is a pilot study. So hopefully we'll just be able to, try what we think might be effective with some women and get some preliminary data for an efficacy trial potentially next. So that is actually all I have. So I think we have ample time for questions and discussion. But in summary, the hormones are highly variable, especially in women of reproductive age. They may influence substance use disorder and likely postpartum relapse to opioid misuse. And they should be considered in concert with each other, as well as with many other factors that we know influence them and over multiple time points. And lastly, there's lots of potential applications. So it's really just kind of an emerging topic area, especially in terms of opioid use specifically. So with that, I hope you have lots of questions. I'm eager to hear them, and I appreciate your attention.